We can cut it down.
All right.
Yeah.
Take one.
All right. So, tell us a little bit about yourself, your name, and the work you do here in the hospital.
Okay, yes, I am Hernando Lyons, a pediatric gastroenterologist. I work at St. John Hospital Medical Center in Detroit. I am a director of pediatric gastroenterology and nutrition at the hospital, and I am also associate professor of clinical pediatrics at Wayne State University. What I do is, besides administrative things, I see patients, children from ages birth to 21 years of age with gastrointestinal problems like gastroesophageal reflux disease, constipation, failure to thrive, chronic abdominal pain, etc.
Thank you. How would you explain what gluten is to a patient?
Well, usually I tell the patient parents, that's what I deal mostly of the time, or sometimes if it is an adolescent, I talk to them. We tell them that gluten is a protein, basically, that is found in wheat, barley, and rye, and that in patients with celiac disease, that trigger an immune response that attack the intestine and that damage the intestine.
Okay, so you had mentioned celiac disease. Can you describe a little bit more about that?
Yeah, celiac disease basically is an autoimmune disease that occurs in genetically predisposed individual where the gluten that they ingest leads to an immunological response that attack the intestine of the person.
How well would you say gluten is understood by your patients when you tell them what it is?
Well, I think gluten is so popular now. I mean, it's a hot subject, a hot topic. Everybody wants to be on a gluten-free diet, but people, the sources that they have when they come to my clinic, parents, the sources that they have is the internet, and you have to be careful what internet site you go because it can be misleading. So most of the people, I mean parents, when they come to the clinic, they already have the information from the internet. But we have a dietitian. If the patient has already a diagnosis of celiac disease, the dietitian go over the gluten-free diet with details and give also and provide to the patient or the patient's parents some sources where they can use, like internet sites that are very good, like the University of Chicago Celiac Disease Center is a good one, or the NASPGHAN, which is the North American Society of Pediatric and Nutrition.
You had said that some websites can be very misleading about the gluten-free diet. And I was wondering if you could talk about the population of people that come to you without celiac disease, but talking about a gluten-free diet to you.
Yeah, there is definitely, that's true. I mean, there are a lot of people that have, for example, I can tell you some of the anecdotes. I mean, patients that come to my clinic, they have chronic abdominal pain. They already have the test for celiac disease, but they want to be on a gluten-free diet because they learned that gluten is not, eating gluten is not healthy, and they want to be on a gluten-free diet. But some of these patients, I mean, we have to be careful because nowadays there are no means to make a diagnosis of non-celiac gluten sensitivity. The only way is to remove the gluten from the patient to see if the symptoms that the patient have improve on a gluten-free diet. But there are no laboratory now that can label a patient, oh, you have gluten sensitivity, not celiac disease. So important here is, I mean, patients basically with gluten sensitivity, non-celiac disease, they have the same symptoms of celiac disease. So we cannot differentiate, based on the clinical history, who has gluten sensitivity, non-celiac disease versus celiac disease. But by laboratory, we can do a test to make a diagnosis of celiac disease. The test that we mostly use is the tissue transglutaminase antibody, which is a marker that is now recommended. There are other antibodies, but this one is not expensive, easy to perform. So if that test is positive, more than 300 or 300, definitely the patient has celiac disease. We did a study, 2 years ago that we presented it as an abstract in one of the meetings of the NASPGHAN about how sensitive and specific is the tissue transglutaminase in diagnosing patients with celiac disease. And what we found was 300 or more, positive predictive value is almost 100%, 97%. From 200 to 300 is positive predictive value was 85%, and less than 100, very poor positive predictive value. So what I am trying to tell you is that there are false, positive and false negative with the tissue transglutaminase. So still the gold standard to make a diagnosis of celiac disease in North America is doing an endoscopy and then a biopsy of the intestine. However, in Europe, if you read the guidelines of the European Society of Pediatric Gastroenterology, they use the cutoff that I just mentioned before, the 300 or more. If the patient has has 300 or more, no need to do the endoscopy with biopsy. They are already confident that the patient has celiac disease. They do endoscopy if it is less than 300. But here in North America, there are no guidelines yet, about that, and we have to do an endoscopy in all patients that have a positive test for celiac disease, like the tissue transglutaminase antibody.
That's very interesting. So there's a lot said there, but let's go back to the gluten sensitivity.
Right.
So non-celiac gluten sensitivity, would it be accurate to say that that type would be a mild form of celiac disease?
No, it's not, because celiac disease is an immunological disease, it's an autoimmune disease. Gluten sensitivity, non-celiac, is not an immunological disease. Different mechanisms, so that we shouldn't say that.
Would you be able to go into describing the mechanisms that might be different?
The mechanism, nobody exactly knows, if you review the data, of non-celiac gluten sensitivity. Is an adverse reaction to the gluten. The symptoms are similar to celiac disease, and the body mounts a response, a stress response, I will say, non-immunological mediated. And the symptoms are similar to celiac disease, and the patient improves on a gluten-free diet.
Okay. Good. Go ahead and explain what you're saying.
Yeah. In Europe, there have been studies about celiac disease and the sensitivity and specificity more than North America, and the North American Society of the European Society of Pediatric GI and Nutrition have established guidelines that 300 units or more is enough to make a diagnosis of celiac disease of the tissue transglutaminase antibody. Less than 300, they will do endoscopy. But here in North America, we do open endoscopy with biopsies to every patient that has the clinical symptoms and has a test, tissue transglutaminase antibody, more than 15, units per ml.
This may be a bit of a personal question, but why do you think that there's the difference between Europe and North America in terms of diagnosis for celiac disease?
Well, the difference is not too much. I mean, it's only the cutoff value of 300. I mean, in Europe, they still do the endoscopy with biopsies if it is less than 300. But they are very confident because I believe all the studies that they have performed, I mean, there is a positive predictive value with the tissue transglutaminase antibody when the titer is 300 or more. Mm-hmm. So they are very confident. And in part that makes sense. I mean, I think that maybe here, I mean, I will not be surprised in the near future that we will adopt also some measures like this. Because that's, it's an invasive procedure. I mean, to do an endoscopy is costly. So I think that, if as a parent, if I have a child that has the symptoms of celiac disease, and the doctor tells me, oh, my child has a 300, I probably will not go for the endoscopy because the risk of anesthesia and the procedure itself. So I think that that's probably the way in the future also to go here also.
How often do you encounter patients with celiac disease and non-celiac gluten sensitivity?
With celiac disease, I see more or less in my clinic 1 to 2 per month. With gluten sensitivity, non-celiac disease, I will say less often. The question usually is brought by the parents because I see a lot of children. 25% of my patients that come to the clinic are functional abdominal pain, which means that the patient doesn't have any organic problem. Is I would say a psychosomatic abdominal pain, and those mothers already navigated the internet, and they found, oh, my child, has abdominal pain, and I read that being on a gluten-free, maybe the pain will go away. And some of them, to be honest with you, some of these patients, not only they have abdominal pain, but they have sometimes diarrhea or constipation, and the parents already, when they come to my clinic, they already put the child on a gluten-free diet. And some of them, the pain goes away, and some of them, they will continue. So these patients, I will tell them, well, if the pain is gone with a gluten-free diet, continue with that for now, and then we have to do a challenge to see if the symptoms come back to establish a diagnosis of gluten sensitivity. Because these patients already were tested, most of them, by the pediatrician for celiac disease. They did the antibody, the tissue transglutaminase, and was negative. They tested for celiac disease already, but the parents on their own, they adopted the gluten-free diet.
What are the possible pros and cons that an individual without celiac disease will encounter when undergoing a gluten-free diet, like health-wise?
Well, without celiac disease, you said, right? Without
celiac disease.
Without celiac disease, well, the pros, I will say, if the patient doesn't have celiac disease, I don't think that will be of too much health benefits. Although 50% of when we do an intervention, we feel better. Placebo effect, psychological effect, maybe they will get better because there is an intervention. So that's, but I don't think that will be of too much health benefit if the patient does not have celiac disease. The cons is a very expensive, diet and difficult to adapt sometimes. So I think that will be the cons, yeah.
Mm. What challenges do patients with celiac disease face?
Well, the challenges, again, I will say that, the adaptation to the gluten-free diet is a very difficult diet. I mean, gluten is everywhere. I mean, a lot of fiber that we eat on a daily basis, and even if it is an adolescent, in hair products, cosmetics, gluten is right there. So I mean, they have to go to a cosmetic free gluten. So that will be a challenge and difficult to adapt, I will say. And again, the cost. I mean, gluten-free products cost the double amount that wheat with gluten cost. So that is a big challenge, I would say.
Would you recommend a gluten-free diet to someone that's not diagnosed with celiac disease?
No, I usually in my practice I do not recommend gluten-free diet if the patient does not have celiac disease, because free diet you can put the patient at risk. Also, these diets are deficient in minerals and vitamins and fiber. And if you read the recommendations, the dietary guidelines in North America, they say that 50% of all carbohydrates should come from a fiber source, which is gluten. So I think that the benefits are not good, especially if the patient does not have celiac disease. So I will not recommend a gluten-free diet to a patient that does not have celiac disease.
Thank you. Any other questions? I've gone through the entire thing now. So all the celiac disease related things are gone. There actually is a study that's coming out of Australia now, comparing gluten sensitivity to the FODMAP sensitivity. Have you heard anything about this?
Yeah, well, FODMAPs, we are using that. FODMAPs is, are carbohydrates, complex carbohydrates that are fermented by bacteria in the intestine. Basically, we use that diet in irritable bowel syndrome now. And the patients with irritable bowel syndrome, they have some of the symptoms of celiac disease. One of the mimickers, I will say, I think that's the best word, of irritable bowel syndrome is celiac disease, because these patients, they have bloating, they have increased flatulence, diarrhea, constipation, and abdominal pain, patients with irritable bowel syndrome. So, and it is important, patients who are diagnosed, that are labeled on a clinical basis with irritable bowel syndrome, to try the FODMAP diet. And if the patient improve, maybe the symptoms were triggered by these complex carbohydrates, which are monosaccharides, disaccharides, oligosaccharides, and polyols, basically. And these substances, they are not digested, some of them, and absorb very well in the intestine, and that what it does is creates an increased osmotic pressure in the intestine, in the lumen, inside the intestine, and that pulls water, and that causes the diarrhea in these patients. So if the symptoms are gone with this diet, we can say, well, the patient has most probably irritable bowel syndrome. But on the other hand, not only there are patients with celiac disease that are on a gluten-free diet, and they continue having symptoms. That's another aspect here. And maybe these symptoms are caused by these complex carbohydrates. So, you exclude also in patients with celiac disease that are already for 1 month on a gluten-free diet, they continue having bloating. Maybe these complex carbohydrates are causing these symptoms.
Is that how you would tell the difference between IBS and celiac disease, or is there further
Well,
testing?
the difference between celiac disease, basically, clinically, sometimes is difficult to make the diagnosis, so you have to do the testing. The tissue transglutaminase antibody in these patients. If the tissue transglutaminase is less than 15 negative, the patient 90, almost 7% positive predictive value that the patient does not have celiac disease. So the patient has irritable bowel syndrome. So you put this patient on a FODMAP diet.
Okay. Well, that's all I have. Oh,
Another question.
Sure.
So if you say you have an individual with
Yes.
who thinks that he or she has celiac disease, like they think they eat products containing wheat and they have abdominal pain, diarrhea,
Yes.
things like that.
Yes.
What would you recommend to them? Like, it's going about, do you think they should just, start a gluten-free diet right away? Should they go see a doctor? Should they?
Well, if the patient, if we suspect clinically with the symptom that you mentioned that has celiac disease, the increased bloating, diarrhea, the first thing is, yes, to see the primary care doctor before they come to me. And the primary care, in this new healthcare era, I mean, we are trying to save more and more. So the primary care should, order the test for celiac disease, which is the one that we use, as I mentioned before, is the tissue transglutaminase. If that is positive, then make a referral to me. And then we will do the endoscopy with biopsies. If the endoscopy confirms the diagnosis of celiac disease, flattening of the lining of the intestine, then we will put these patients on a gluten-free diet. Our dietitian will review the diet with the parents or the patient. And also we measure vitamins, liposoluble vitamins, because these patients with celiac disease, they have malabsorption of vitamin A, E, and D. So we measure, these three vitamins. And not only that, these patients also, they have secondary lactose malabsorption because, there is damage of the intestinal, lining basically. So the lactase enzyme that split the lactose that is on the milk and dairy products in glucose and galactose is missed in these patients if they have a severe damage of the intestine, so they will not digest the lactose. So we need to put these patients on a lactose-free diet at least for a month, because if the patient continues the gluten-free diet, there is a biochemical and architectural, I will say, recovery of the intestine in a month. So after a month, we put the patient back on milk and dairy products. But
So-
the gluten-free diet is indefinitely, because as you know, one of the problems with celiac disease is they don't follow the gluten-free diet. If the patient has celiac disease and doesn't follow the gluten-free diet, that predisposes that individual to other autoimmune diseases like insulin-dependent diabetes mellitus, Hashimoto thyroiditis, and also cancer. Cancer lymphoma of the intestine is 3 times more often in people with celiac disease than the normal population.
So speaking of like lactose intolerance,
Yes.
so speaking of lactose intolerance,
Yes.
is there a relationship that you could like compare and contrast between non-celiac gluten sensitivity and lactose intolerance? Is there a similarity between those two?
Well, some of the symptoms are, people with lactose intolerance, they have the increased flatulence, they have the increased bloating, they have the diarrhea, they have abdominal pain, and they have nausea. So some of the symptoms are also in non-celiac gluten sensitivity. So that's the reason I mentioned before. I mean, when we have these situations, These are irritable bowel syndrome light pictures, and what I usually tell the patients are, we need to rule out your child has irritable bowel syndrome light picture. We need to rule out the mimickers of irritable bowel syndrome. What are the mimickers? Celiac disease, lactose malabsorption, parasites like Giardia is another mimicker. So, and inflammatory bowel disease like Crohn's disease and ulcerative colitis. And then we have to do some blood work on these patients to rule out the mimickers. Yeah. But there is a lot of overlapping, as you can see, among all these diseases. So, based on clinical history, sometimes very difficult to make a diagnosis because irritable bowel syndrome has some clinical criteria, but these criteria were created, by the wrong criteria. Expert of people met in Rome and developed these criteria, which are, abdominal pain that is relieved by a bowel movement, alteration of the bowel movement, then additional symptoms are increased bloating and increased flatulence. But again, these other diseases like celiac, parasites, lactose intolerance, or inflammatory bowel disease can mimic that. So
I thought of one more question.
sure.
So you are primarily working with children, right?
Yes, from birth to 21 years of age. That's right.
Have you gotten to work with any patients over the age of 21, and do you see a difference in a young person with celiac disease and an older person?
Yeah, well, I, since I am a pediatric gastroenterologist, I don't see patients above 21 years of age. So, but I can tell you from my readings and my, when I prepare for lectures and those things, I mean, celiac disease in adults. Well, to start with, celiac disease can present at any age, basically. And a lot of adults, it's important that you made that question, because a lot of adults that are diagnosed with osteoporosis, they have celiac disease. The osteoporosis that they have is due to celiac disease. So celiac disease has the classical, let me just tell you that, the classical picture of celiac disease, you don't see it in practice. I don't see that. If you review the literature, mostly of patients with celiac disease, they don't have any symptoms. They are asymptomatic. From 7 patients with celiac disease, 6 do not have any symptoms. 1 have symptoms. If you ask me, how many patients do you have with symptoms and without symptoms? I will say, mostly of my patients are without symptoms. And then you will ask me, how you discover them? And so the reason I discovered that is because I, screen relative of somebody with celiac disease. For example, I was telling Alex here the other day that I have a family of 4 girls. One of them, they presented with diarrhea, bloating, abdominal pain, and the tissue transglutaminase antibody was positive. We did an endoscopy. We made a diagnosis of celiac disease. So it is mandatory to screen the first-degree relatives. When you have somebody in the family with celiac disease, there is a 10% chance that a first-degree relative will have celiac disease. So we screened the 3 sisters, and all of them were positive. More than 200, the tissue transglutaminase antibody, and these 3 girls, they didn't have any symptoms at all.
Wow. He was actually talking to us about that in class as well. So I'm really glad that that was brought up too.
And here's another, I know I asked you this question before, but now since we do not see since the celiac disease is asymptomatic.
One moment.
So since celiac disease is mostly asymptomatic, most people don't even know they have it. Would you? Why isn't there genetic testing done at birth with for this disease?
Well, the genetic testing, let me tell you, there are two markers for celiac disease. There is the HLA-DQ2 and DQ8. The problem is with these markers is they are present in 30% of normal population. So there is a pitfall here that why to do a screening in everybody, genetic testing, since these markers are present in normal people. So usually we do not do genetic testing for celiac disease unless the only conditions that we do that is when there is a dilemma. The pathologist, you did an endoscopy and the pathologist tells you, I cannot make a commitment of celiac disease. The biopsy, the histology is suspicious, but then you have a patient that have the typical symptoms of celiac disease, the tissue transglutaminase is positive, so then you do the markers. If the markers are positive, I am sure with this history and the tissue transglutaminase that this patient has celiac disease. So these are when we do this genetic testing in these situations, but routinely, we don't do it because that problem that these markers are present in normal population 30% of the time.
How many patients actually ask you about the mechanisms of action of celiac disease and gluten sensitivity?
Well, the mechanism of actions, gluten sensitivity, non-celiac, you will say gluten sensitivity, the mechanisms, I think that nobody knows, what is the mechanism, but basically, it's not an immunological reaction. That is definitely, we are sure about that. It's an adverse reaction to the gluten, and the body then creates a response, a stress response, I will say, that with GI symptoms, gastrointestinal symptoms that are similar to celiac disease, and the patient improve on a gluten-free diet. But the exactly mechanism, I don't think that nobody knows, and in the reviews that I have made, I haven't found, a mechanism, basically. But regarding celiac disease, yes, we know that is an autoimmune disease, basically, that occurs in patients that are they have the genetic makeup to develop celiac disease when there is exposure to gluten. So the body mounts an immunological response, basically, and then there is a destruction, there is a production of cytokines, and the T lymphocytes destroy the small intestine, the mucosa of the small intestine, the lining, basically, and production of antibodies like the tissue transglutaminase, the anti-gliadin antibodies, the endometrial antibodies, and these are the markers that we use to make a diagnosis.
I guess this is kind of a broad question, but
Sure.
Just like, what are your general opinions on non-celiac gluten sensitivity? Do you think it's true? Do you think it's more psychosomatic, or?
Well, non-celiac gluten sensitivity, I believe that, exists because, patients improve on, that have the same symptom of celiac disease, improve on the gluten-free diet, and they are negative for celiac disease. So I have been talking to my adult colleagues, and they see that more than me. Adults see that non-gluten, celiac, non-gluten, sensitivity more than in pediatrics. So the non-celiac disease gluten sensitivity, adults definitely see that more often than me. So I believe on that because the fact is that they improve on a gluten-free diet.
Any other questions?
Thank you very much.
Okay.